Morning. Okay, so really want to thank the forum, IOM, for asking me to come out and talk with you guys this morning. Really appreciate it. Interestingly, I was actually here about 2 weeks ago to talk at a workshop on clinical trials data sharing. And I think what you're going to see is that some of the things that were talked about there are strongly applicable in this environment. But I'm going to try and draw upon several examples that have specific implications for oncology research. I'm not going to actually tell you that de-identification saves the world. I'm just going to give you a little bit of context for what this actually means first. I do have to give you a couple of points of disclosure. Two, I am a paid consultant to Sanofi Aventis as well as Celgene. I've been working with them for several years on advising on de-identification of their data sets and disclosure to the public. And from 2009 to 2013, I was a consultant to the Office for Civil Rights at HHS, helping them put out the de-identification guidance that was alluded to earlier. Okay, so given enough effort, what am I saying here? Given enough effort, you can break into any system. Seriously. It doesn't matter like how much barrier somebody puts in place, you can break into it. I don't care what people tell you. However, it's not just effort. There are many different axes here. It's given enough effort, given enough time, given enough incentive. Somebody really has to be incentivized to break into the system. Sometimes they want to break into the system to go, woohoo, I did it. Sometimes they want to do it to actually misuse the information in a certain way. The incentives change. It actually changes the way you end up protecting the system. And given enough money, people have to actually have sufficient capacity to perform these types of things. Okay, so that said, if this moves forward, there was a major claim, and there continues to be a major claim, which is that de-identification has failed. It has failed miserably to protect actual privacy, and that we shouldn't be having discussions around this topic anymore, and I shouldn't be standing here. This all dates back to the mid-90s, actually. And in the 90s, what we basically had was a federal administration that was trying to revamp healthcare. And they went around to all the states and they said, what do you need in order to make healthcare better? What policy decisions, or how do we evaluate policy? What type of data do you need to do this? And this was the type of information that was suggested. You take some aspects of the patient, such as what were they diagnosed with, what were procedures performed, how much did it cost, where did they come from, and then let's just do some comparative effectiveness research. Unfortunately, the amount of information that was collected and disclosed may have been a bit too detailed. And there was a demonstration attack that was run to identify William Weld, who was the governor of the state of Massachusetts, who was basically getting an honorary degree and was speaking, and he collapsed and nobody knew what happened to him. He was admitted to MGH, and LaTanya Sweeney took publicly available information in the form of voter registration data, which was a cost of $20. And then she knew that he had a certain 5-digit zip code, a certain birth date, and obviously he's a male. Crossed these two pieces of information, and out popped out his identity and what he was diagnosed with, even though he wasn't disclosing it. This was a problem, right? This was a claim that if you try to redact things like an individual's name, that you could not actually protect their identity. But that actually begs the question of what is de-identification? Was that actually de-identified data? And let me put this in context, because it's not just what's going on in the US. You really do have to think about this in the broader world, because these trials that we're talking about, or the studies that we're trying to do, are growing to become multinational studies pretty quickly. Now, in the European Union, they have a definition with respect to what is personal information, and they say that when you're protecting data, they say that the principles of protection shall not apply to data rendered anonymous in such a way that the data subject is no longer identifiable. Now that's a bit interesting, because in the US we have a bit of a slightly different definition, where we say that in HIPAA particularly, that information does not identify an individual, and there is no reasonable basis that the information can be used to identify an individual. So there's this reasonable clause that exists in the United States, which suggests that we have more of a risk-based model than what's actually going on in the EU. It's actually quite intriguing. And then, as was alluded to before, you have two different ways in which de-identification actually can be applied with respect to health information. One is this safe harbor model that we've heard so much about, which says, remove the 18, show that you have no actual knowledge, and the data is good to go. And the other one is what they call the statistical standard, or what in the regs is called expert determination. And this just doesn't go. There we go. You apply statistical or scientific principles to show that the data is sufficiently protected. And what that means is that there's a very small risk that the anticipated recipient could identify an individual. Again, there's an interesting reasonableness clause here. Okay, so where exactly has this come from? Safe harbor was actually an extension of limited data sets. And this is the easiest way to think about it. It says, what could you actually have under a limited data set? Let's pull out a couple of things that you were allowed to have. Specifically, it said dates are a concern, dates of birth, dates of death, dates of service. Geocodes, where I can actually zoom in on where the individual is located. That may be a concern. And then there was this catch-all. It said any other unique identifying number, characteristic, or code. That ended up being really confusing for a lot of people. So we made some clarification in the guidance that said, look, what that meant was it's a barcode. A barcode is not listed in these first 17. But if you're using that to track people, there's a corresponding identity there. Don't disclose that. So you should practice what you preach, right? This is what we've actually done at Vanderbilt. I want to give a little bit of an example of how we've actually done the identification of health information for large-scale research studies. We constructed what's called BioView, which entailed taking the entire electronic medical record system, de-identifying it, and combining it with de-identified DNA that we collected in the context of routine care. We've assigned one-way hash identifiers to all these records so that we can track these individuals prospectively, but we never have the ability to go back and recontact them. That will be discussed later on. I want to stress that this was not something that was done lightly. You may have heard about this project. This was not a project that we just said, hey, wouldn't it be really cool if we could just reuse medical records and then tomorrow we just did it? It all began with a whole series of focus groups and community engagement. Without the community involved, this never would have moved forward in the way that it did. This started almost 4 to 5 years before the actual project got up and running. And we have a community advisory board that continues to be involved with the oversight and the daily workings of this resource. So we did a lot of feasibility testing. In addition, one thing that's important to recognize was that we actually did a dry run of this system. We didn't just go live and say, hey, we're going to take your blood and combine it with your medical records and just go. We told people that we were going to do that, and then we didn't. And we said, if you have a problem with it, you can call in. You can find out more. And we wanted to see if this was something that, even though people said they were okay with, we wanted to see if they were really okay with it once it started going forward. Unfortunately, Dan Macy stepped out of the room, but the phone number that they got to call if they had a problem was my department chair at the time, and they got to call him and complain. All right. This was done under a designation of non-human subjects by OHRP. We actually went to OHRP, got their approval on it, had a long discussion with them, and then went live in around the middle of 2007. In doing so, what this entailed was, and there were a lot of challenges here. One of them is that the majority of health information that gets used for research purposes now in this big data context, and I'll talk more about that in a minute, is natural language. It's free text. It's doctors that are dictating what's actually wrong with the patient, or it's a discharge summary that actually tells you everything that was going on and what they're supposed to do once they leave the hospital. And as a result, you end up with little nuggets of identifiers strewn throughout the record. It's not just, hey, remove a name. It's actually, hey, go find the name and remove the name. Not always the easiest thing to do. So this is just an example of a note that this is actually a variation of a note that exists at the Group Health Cooperative of Puget Sound. And so you can see there's a name of an individual, there's a date, there's a doctor name. It's not the actual information. But that's the type of information that you're trying to redact. I'll come back to why it was group health in a moment. But we did a feasibility study. We ended up working with a company that was a spinoff from the University of Pittsburgh that was called DID. They had developed a software technology that they had been using in-house at UPMC for a number of years. And so we wrapped that with some of our own software that we developed, and then we applied it to our resource. We demonstrated that we could remove greater than 99.9% of all of the explicitly detailed identifiers. Now, when we did that, there were a lot of people who came to us and said, wow, we'd really like to do this. And we said, wow, it's really expensive to do that. And they said, yeah, we're not going to spend that much money to pull this off. And so we started looking into how could you make this more cost effective. So through a couple of grants and some research projects with the MITRE Corporation, we started developing a new piece of software that was called MIST. This is known as the MITRE Identification Scrubbing Toolkit. There's a paper that's listed up there. But what's interesting about this is that where the old software was just rules-driven, lots and lots of rules that somebody has to hand annotate and define over time, and it takes a long time to get that up and running, we created a machine learning environment. And this is the interface that we ended up designing that allows people to look at a medical record, it tokenizes it, they get to annotate where the identifiers and the types of identifiers are in the document, and then we actually have the system go off and learn a grammar around what these identifiers are occurring within. And then we apply that to the records in the future to a much larger scale. This is one of the challenges. This is about scalability of this type of protection. We did a feasibility study with about 1,200 documents from Vanderbilt. This was discharge summaries, laboratory reports, letters and orders. What we saw, now note, this is actually without any additional dictionaries of patient IDs or places or anything. This was just the grammar. The precision of this was on the order of around 90% to 99%, depending on the type of document you were using. The laboratory reports had a very terse grammar, wasn't always the easiest to find the things we were interested in. But that the recall, in terms of, did we get everything, was a little better, 95 to 99%. So precision was if you claim it was an identifier, was it actually identifier? Recall was, did you get all of the identifiers back? A couple friends of ours at the Cincinnati Children's Hospital did an assessment of this type of technology to see, could you still use those records for research? Specifically, they were looking at medication extraction from the natural language. One of the things that they showed was that this is the result, as you're looking at, with the original data and an automated extraction tool. Precision of about 96%, recall of about 89%, balanced F measure, which is basically just the mean here, about 93%. When they subjected their data to the de-identification procedures and then retested this, these were the results they got. You notice it's almost exactly the same. In many instances, it was actually slightly better. And one of the reasons for that, and we've seen this in a lot of settings, is that when you remove the identifiers, it actually acts as a noise dampener, and it makes it easier to focus on the information you're interested in actually studying. This is the type of situation that you end up in. In some instances, it's not perfect, right? This is where the risk comes into play. You are never going to be able to guarantee that you get 100% of the identifiers. And then you have to prioritize in terms of what is this information going to be used for? What is it going to be exploited for? But in the process, we ended up recognizing that you could actually hide this information. So despite the fact that things made it through, one of the reasons why it makes it through and it becomes concerning is that it sticks out like a sore thumb. Right? Notice the name Lynn shows up, it's right there in your face. Now, granted, I made it red on a background of blue, but if you're reading the document, you're going to see there's a name there. So one of the things that we've been doing with friends of ours at the Group Health Cooperative is working on what we call text-based steganography, or what we call hiding in plain sight. You take what you've redacted, and then you resubstitute, or you substitute in things that look real. They're not actually real, but they look real. We ended up doing a study on this concept with people up at Group Health using a test case of about 100 oncology notes. Now, there's a lot of numbers here. What I'm doing here is just highlighting what the expected precision would be if you had somebody just guess at random. Okay? How well are they going to be able at saying this was an individual's identifier? So for names, we had a situation where if you guessed at random, you would have been right about 17% of the time. Dates, you would have been right about 9% of the time. And so we took this to a couple humans, and we said, can you tell the difference? The first one that we took it to, they were really bad. Now, one of the reasons why they were really bad was because they just didn't even know when to guess. We just said, hey, tell us, is this an identifier or not? They go, I don't know what to do. All right, so we then took it to somebody and we said, you have to guess. And when we did that, they actually were a little bit better than random on the patient names, but they were worse with dates and with many of the other features. Now, this was a very naive implementation of what we did. This was like we threw this together in a couple of weeks. We tested to see if it would work. But one of the results of this was that even with the residual information, this was just stuff that was left over. This is in the context of like thousands upon thousands of terms that were identifiers. When we clued them into something, they did a little better. But overall, the effective performance of the de-identification of the system was super high. So NIH is actually now sponsoring us to do much larger studies on this. That said, even when you do hide information in this situation, you end up in the following case. You have semantics, right, that are not explicit identifiers. When it says, the senator's wife was here for breast cancer treatment, it's really difficult to determine, well, first of all, is that the current senator? Was that a previous senator? Regardless, you end up in a situation that's a little uncomfortable. And so as a result, you don't see a non-natural language moving beyond the barrier of the institution that actually generated it. Also, recognizing that that's a potential problem, one of the things that we do locally is we use data use agreements. And we end up saying, look, it's not just de-identified, it's de-identified with a potential concern. We don't want you to exploit this information. Okay, so that is safe harbor. Let me turn my attention real quickly towards this notion of this expert determination. This is the actual language. It's risk. Let me just leave it at that. There were a lot of questions about what do you actually do to protect the information using a statistical model. I'm not going to go through any of the math. I'm going to show a conceptualization so that you get an idea for how this works. What we've been doing is we take a patient cohort, we then subject it to safe harbor, and we say how much protection's in safe harbor. We then look at population counts or the broader count. We say, so how much risk is this data set in? And then we'll start fiddling with some of the parameters. The geocodes become less coarse or more coarse, or the dates become less or more coarse. And then we check to see if that information is below the amount of risk that safe harbor afforded us. If it is, we say it's good to go. If it's not, we say go find something else. Here's an example of how we've applied it. This was a cohort of 3,000 patients at Vanderbilt that we were doing a genome-wide association study on. Notice that there were 12 people in this population over an age that was not permitted under safe harbor. You can't give out the explicit ages for somebody who's over 89. So we started looking at different policy options. So we said, hey, you could remove the gender. That's really difficult to do if you're disclosing DNA. You could obscure the race a little bit, so you could combine Asians into others, or you could also end up combining certain ages. And the risk here is the expected number of people that if somebody guessed the identity of, how often they would be right. In our data set of 3,000 people, as safe harbor policy, they would have been right about once, if they guessed. And that the risk of these other policies was they were all less than 1. So we said these are all options that are feasible. We did this on a much larger scale with a bunch of cohorts from the Electronic Medical Records and Genomics Network. Some of the challenges in this was that the Group Health Cooperative has been studying a phenotype of dementia. That's what you see at this top one, where the majority of their population was over the age of 89. Which makes it really challenging for reuse of this data if you're going to be doing a continuous regression. There were other ones. Marshfield, for instance, had about 10% of their population that was over that age limit. Now, these are a bunch of different policies just summarized into green, good, red, don't go, or no good. We were able to get policies that said, look, you could do age at 5-year bins or just ethnicity generalizations for just about all of these populations. Group health, that dementia cohort was a thorn in our side. We came up with one policy that said you could do age at 10-year bins. Basically, it's just an illustration that says sometimes de-identification doesn't get you all the way there, right? But sometimes, a lot of the times, it does. Okay, I think I've got, can I take a couple of extra minutes? Great, because I think we're really ahead of time. See, that's what happens. I get all of the additional leftover time. All right, so this is forthcoming data from Sanofi. We have been doing de-identification of oncology trial data sets for them for public dissemination into a project or a data resource that's called Project DataSphere that's going to be housed at SAS. This was, first of all, I should make it clear that this trial data, there is no free text. It's only structured data. It basically includes, how much of the drug was an individual taking, when were they taking it over time, what was the time between the events. This is a list of the things that we did to this data set. It's not nearly as important as understanding why we did this. We basically used population and data set specific distributions to show that, again, that the risk was no worse than safe harbor. Safe harbor on this particular policy or this particular data set, there was already a small risk of identification. But that type of a policy was not sufficient for what Sanofi wanted to do to share their data. However, when we actually removed all the things that they said you could remove, we were able to show that the risk was even significantly lower than what Safe Harbor would have put a traditional data set in. One of the challenges, however, was that this is data in a multinational setting. There were about 40 countries that were contributing data into this trial. And what I showed you before was just for the US population. We use population statistics in a particular country. So we extrapolated this analysis by simulating the diversity of the ethnicities and the age groups in these other countries where the data was collected. Let me give you an example of how this ended up working. We simulated several different policies, ones that were more diverse than the US, some that were less diverse than the US. This is, it's the population size, because that matters when understanding identifiability, and then the percent of that population that would be identifiable. In a country that was more diverse than the US, relatively small countries, 1 million, 5 million people, a couple of the European countries, they end up being very identifiable individuals. In the US, which ends up being at around 300 million, it's very well protected. And then you can see that as the diversity goes down, so too does the identifiability. This ended up being our threshold, and this is also how we came up with the decision criteria. It said no region or no geographic region that had less than 10 million people was going to be disclosed in this data set. So we ended up coming up with about 5 regions in the world that we ended up saying where the data ended up coming from. Just a couple of small points. It's risk, right? Identifiability is this issue that has a proportionality component. It's about the distinguishability of the data, but it's also about the replicability, and it's also about the availability. What do I mean? So a drug dose can be unique, okay? But it may not be accessible to the public in any known resource. So you also have to recognize that your adversaries usually have incomplete knowledge about the world. And the reason why I bring this up is that there are a lot of studies that say it's kind of like the Mad Libs style of privacy. Pick your favorite feature, and it's going to distinguish you in a population. We've done studies with demographics, diagnosis codes, lab tests, DNA, and just about everything else. There are test studies to show you can breach the dam, okay? Some of these require a lot of effort, some of these require little effort. The reason why I'm bringing up diagnoses at the end of this presentation is that I'm going to show you what you can do with big data. There's a concern with diagnoses that they uniquely identify someone, that the combination of them make it easy to find you in a population. We've actually published those papers. And what I'm going to say is that the big data problem is actually not necessarily the end of privacy. Let me give you an example of one protection model. This is a data set where we used what's called k-anonymity. It's a way of regularizing the data. You say for every piece of information I disclose, or for every individual's record I disclose, there's at least k-1 other people that have that. That's the way you prevent identity disclosure. We looked at how well we could retain these diagnoses, because we removed some diagnoses on this population I was talking about from Vanderbilt before. And these were all of the diagnoses or phenotypes that we were able to support validation on. We couldn't support everything, but there were a lot of cancer patients that we were able to retain most of the information for, including renal cancer, prostate cancer, lung cancer, pancreatic cancer. Now, this is interesting because this is a data set that was not originally collected for cancer research. This was collected for a QRS study with respect to the ECGs. The reason why we're doing that is that the research is heading towards what we're calling phenome-wide association studies and not just genome-wide association studies. So you don't just want to support the validation of a particular genome-phenome association. You want to support discovery across the entire phenotype of somebody. So this is an example of a phenome-wide association study. It's a particular point of the genome. And what you see here are all the possible phenotypes that these individuals could have had. And so these were two notable pieces, notable phenotypes in terms of cardiac arrhythmias and atrial fibrillation that would be interesting for further investigation. Getting at the end here, I promise you. I get 30 seconds. The reason why I say big data can mean big privacy is that most privacy models or test cases or demonstration attacks that have been run to date assume an extremely strong adversary. They know that somebody's in a very, very small cohort, which is almost never the case. In the real world, people have much limited identifiability. This is what's called a QQ plot. Basically says on that x-axis, this is the p-value of the original association. The y-value, the y says what is the p-value of the anonymized association. You want something along the 45-degree axis. It says it's perfectly correlated. This is if your adversary knows somebody's in a cohort of 5,000 people. This is if they're in if they know that they're in a biorepository of about 100,000 people. We had an algorithm that tries to protect the data for the support of any type of a study. And that's why things actually get a little bit more fuzzy here. But when you actually anonymize in the context of all 1.5 million people, and you look at a realistic adversary, turns out you can actually support the types of studies you want to support with almost perfect accuracy and still have the protection guarantees that you anticipated. So there's a lot of other things I wanted to talk about, but I'm going to stop because I'm clearly over time. But hopefully this gives you some insight into what de-identification can do and what it does do. All right.